It's an honor for me to address this topic, and I can keep this very short and just say, well, all papers published by BJS are ahead of their time, so let's just stop here. But I think that's probably too quick, and I'd like to go over a few issues with you. Now, first of all, it took me a little bit of time to get here because we had a new queen, the queen abdicated, and we had a new king appointed in the Netherlands. And this is probably what then sort of creates a new link between the BJS, which exists for 100 years now, and the 123 years ago, we had the last king in the Netherlands. We always had queens in between. And 2013 is the year that marks this new liaison by which we can easily remember all of this. 2008 was the year that somebody took the decision to take me on board as an editor of the BJS. Maybe that is a regrettable decision. We'll find out after this talk. If I go to London for the editorial meeting, I usually travel by Eurostar, and that is the train that goes underneath the channel and then comes into St. Pancras railway station. And that just sort of took me to the Eurostar registry. And I'm not a vascular surgeon, so I'm not going to sort of dwell on this for all too long. But Eurostar registry reported on complications and secondary interventions after endovascular repair of abdominal aortic aneurysms with a 10% reintervention rate per year. That was in the journal then initially called a failed experiment. But probably it wasn't, because we learned quite a lot of that. And certainly it was at the beginning of registries being used in surgery. One of the papers that I find very interesting and that I think deeply influenced surgical practice in a very broad sense is the paper by Henrik Gallet from Denmark that was initially not believed because he said that you could operate on a sigmoid cancer and get the patients discharged after 2 days. His reasoning behind this was that if you reduce the insult of surgery, and if you use a multimodal intervention, you can relieve pain and exercise the patient, take out drains and tubes early, and then the patient recovers faster and can go home earlier. Initially, I said people didn't believe this, but then people started trying this, and it was actually repeated. And 2 decades later, we tried this in the Netherlands and implemented this as a new guideline for perioperative care in 1/3 of the hospitals. And showed that we could also repeat in hospitals with no prior experience that you can reduce length of stay by approximately 3 days. So apparently that works. Equally, as a matter of influence on my personal career, we looked at this in a series of hospitals in Northern Europe, and we showed that if you look at recovery, defined as the ability to go home because you have no infusion anymore, you've passed your bubbles, and you have no requirements for analgesics anymore, then you can see that patients are actually considered recovered at day 3, but they don't go home yet. They only go home quite a bit later. This is when they are actually discharged. And this is what we learned from enhanced recovery programs, that there is some sort of societal or hospital influence on the difference between when patients are actually recovered and when they actually go home. This was also used as an implementation strategy in your own country for the 18 weeks sort of program, where Henrik Gallet and other people with experience in enhanced recovery were sort of invited to help implement this strategy. Equally, enhanced recovery was subsequently extrapolated to other types of surgery where usually perioperative care is very sort of sophisticated, and surgeons are always concerned that things go wrong, like in pancreatic duodenectomy. But it was shown that that works equally well with no increased risk of complications. Subsequently, a society for this perioperative care program was raised, and also the first meeting in Cannes recently in the south of France, and it was quite successful. As a personal sort of thing, I thought we had to eradicate drains and tubes and nasogastric tubes And I thought that was quite sort of clever and, let's say, ahead of time. And so we eradicated the nasogastric tube in the Netherlands, and we tried to do pancreatic surgery with no drains at all. So I thought that was very sophisticated, but actually in 1972 already, Tinkler said that there's actually maybe no reason to use nasogastric tubes at all. And going back further even, Gray Turner said in 1916 that drainage tubes are valuable aids in surgery, blah, 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 blah. All the more reason why care should be exercised in their routine employment. And basically, if you look back at intra-abdominal drains after surgery, these date back from wartime and from a time when we had no CT scans and no ways to put in drains after you had closed the abdomen. By now, that has changed. We have CT scans and we can put drains in when a patient develops a complication, so there is no need to put them in before that patient has a complication. And that was also confirmed in 1976 by drainage after cholecystectomy fails to demonstrate an advantage or a disadvantage. So actually, the papers I published were not at all ahead of their time, and that's probably why they were not in the BJS. Then something that radically changed the surgical world is probably the introduction of laparoscopic cholecystectomy and subsequent extrapolation of this technique to all sorts of other procedures. Published in 1993. It's not the first paper on the subject, it's just to illustrate that that really changed the world of surgery radically. We currently often think that so-called patient-reported outcomes are very modern, but they actually aren't, because here's a survey from 1979, looking at a survey of patient opinion on gut irrigation. They actually compared two types of gut irrigation, and the patients gave no preference to any of them. Actually, probably they should have compared irrigation with no irrigation, and then the patients probably would have had a preference, because you probably don't need to irrigate the bowel prior to colonic surgery. Peritoneal carcinomatosis. 8% of people with a primary colorectal cancer develop carcinomatosis of the peritoneum, and these patients usually were declared inoperable, incurable, until people started investigating the role of aggressive cytoreduction, hypothermic intraperitoneal chemotherapy. Probably one of the first papers in BJS on this topic was from a Dutch group who spent quite a bit of work on this topic, and they showed that actually you can improve survival of these patients and probably also cure them as long as you get sufficient reduction of disease load. Next paper I would like to focus on is a paper from Gilles Montin from Geneva on the so-called liver-first approach. They discovered actually that in patients who had rectal cancer and synchronous liver metastasis, that if you gave radiochemotherapy in sufficient doses, that actually the sort of window would sort of emerge where you could take out the liver metastasis and wait what happened with the rectal cancers. Because we all know that if you do a low anterior resection in rectal cancer and you get an anastomotic leak and the patient has a liver metastasis, you'll never get to the point where you resect the liver metastasis, because the patient will endlessly suffer from complications in the pelvis. So they reversed the sequence, and then actually by doing the liver resection first, they discovered that in due time the rectal cancer disappeared. And this has been propagated by Haber-Gamma, non-operative management of rectal cancer after neoadjuvant chemoradiation. This actually is a very interesting topic, because now at the ESA meeting in Bonn last month, people presented data on esophageal cancer management, where they also suggested that there may be a selected group of patients where you can imply this wait and see policy for primary cancers. In the global epidemia of obesity, I don't think I can ignore one of the first papers on the treatment of morbid obesity by means of surgery. And basically at that time, Mason had introduced the vertical banded gastroplasty, as a very efficient sort of therapy, although that later was obviously recalled because of the many complications this treatment had, and the more efficient other treatments with less complications. I'd like to end with a little note on the future of surgical journals in the electronic publishing era. This is a paper from 1996. I bought my first computer in 1992. I was a little bit behind, I agree, and wrote my PhD thesis on it. It was a monochrome screen, green or orange, I could pick. As a non-monarchist, I chose the green screen and typed my PhD thesis on it. And the hard disk had a memory of 25 megabytes, which would hardly keep my presentation, or it wouldn't fit in it. So this paper was probably ahead of time. We still discuss this with the BGS editorial colleagues and editorial team. And I do think that obviously in a few years will be paperless. And if you consider that, one could say that any electronic paper now is ahead of time because it will only appear a few weeks later in paper in the journal. Thank you very much.